We're going? Easy. Okay. So week 10. I believe you guys are starting thorax this week, so that's what we did last week. Because we just want to give you a little bit of like a heads up on all the funky cardio terms and stuff that you're gonna need to know, so you don't get absolutely shook when you start cardio. So this week we're doing a bit of cardiac anatomy, embryology, which I also believe you're gonna do this week, and then Zen is gonna continue with a bit of physiology and histology. So we're starting off with cardiac anatomy, and this is just kind of reviewing from last week. So we have the basic structure of the heart. As we said, we have two atria, right and left, and two ventricles. Blood enters the heart on the right side, goes out to the lungs, comes back into the left side, and then out to the body. And you have all your blood vessels, your superior and inferior vena cava, and then your pulmonary arteries. I was going to say veins, although no, that's not a vein. Pulmonary arteries, and then come back in via the pulmonary veins, and then out via the aorta. So today we're going to talk a little bit in more detail about, yes, we mentioned valves last week too. A little bit more in detail about like the atria and the ventricles and all the weird funky shit that I'd never heard of in my entire life, and then they brought up in the anatomy book. So start off with the atria. So their function is essentially to contract and relax their walls to pump blood into the ventricles. Although, as I believe Xenia may have mentioned either last week or will mention this week, as you can see, because of gravity, a lot of filling of the ventricles is actually just due to like passive filling because of gravity. It will just, flow into the ventricle. But the atria do somewhat contract to push the last like 20% of blood in. I should have put a picture on this slide. Between the atria, you have the interatrial septum. So that's this kind of wall between them here. And it's basically just a wall of tissue. And the main feature of this interatrial septum is something called the fossa ovale. This becomes quite important in embryology, which we'll talk about later, but just keep in mind these words, fossa ovale. Also, each atrium has an auricle. Why did I not put a fucking photo? Okay, I'll use the photos coming up. Each atrium has an auricle, and it's essentially part of the atrium, but it's like a little like pouchy bit on top. So that's your atrium, and this is your auricle. And these kind of don't serve any particular purpose. They just kind of exist there, but you have to know they exist. And it's basically a little sac. Provides a little bit of extra space. And these are lined with something called pectinate muscle. So this is muscle with a ridged surface. So the reason why that's important is because, as you can see in the normal atrium, that's quite smooth, right? But here, where it was the auricle, it's rigid. It's ridged, not rigid, it's ridged with pectinate muscle. So that's just because of different embryological origin, and we'll come back to that later. So if we talk about the right atrium, it receives blood from the superior vena cava and the inferior vena cava, as well as this thing called the coronary sinus. You can see a little tiny thing here, the little purple thing, that's the coronary sinus. And that is basically the vein that drains the heart tissue itself. So you get coronary arteries that go and supply the heart, and that's what's fucked when you have a heart attack. And then obviously you have to drain the blood, and it drains through all your veins into your coronary sinus and into your right atrium. Yep. The IVC also, so you have superior vena cava, inferior vena cava, and the inferior vena cava also has a valve called the eustachian valve. I think there's something, that's not super important. It's just like, not everyone has it as well, but I think it's just like a landmark thing. Now, embryological features. This is where it can get a little bit confusing. And you're probably wondering, what the fuck are all these words? And to be honest, same, I had to Google all these. You only really have to know this to answer the questions in the anatomy book. And then I don't think they'll ask too many questions about it on the exam. It's just like, I don't know, fun fact. But it does help to kind of understand it all. So the fossa ovalis, as I said, remnant from the foramen is like an embryological thing. We'll explain that later. Then you have the sinus venarum, the crista terminalis, pectinate muscles, and the terminal sulcus. And they're all different things. The reason I put them all together is because they all kind of interrelate quite closely. So the sinus venarum, you can see there's like this crest thing. The crista terminalis is like this line here, and the crista terminalis basically marks where it changes from the auricle to the atrium. And the terminal sulcus is the crista terminalis, but on the outside, so it's the same thing. It's just like the surface landmark. And then the pectinate muscles, as we mentioned, are these ridgy bits. So in the embryological heart, the auricles actually come from a different place from the atria. So this is why they're made of two different tissue types. That's why you have your rough bit and your smooth bit. So pectinate muscle lines the auricle, and they kind of, quote unquote, originate from the crista terminalis. It's kind of this crusty bit, and that like demarcates the change between pectinate muscle, so ridge muscle, to smooth cardiac muscle, so here. So imagine if you flip that back, where the crista terminalis would be, it's where the smooth muscle would start. And then on the outside is the terminal sulcus, which is basically this really deep groove that you can sometimes see in the heart. And then the sinus venarum is just like the smooth part. So the pectinate muscles are the opposite of the sinus venarum. So pectinate muscles are rigid, sinus venarum is smooth, and then the terminal sulcus and the crista terminalis are essentially the same thing, just on the inside and the outside of the heart. These are all very confusing words, completely understand. But you know, the anatomy tutors can be pretty picky and just ask you shitty questions. So it's useful to have that knowledge. Are there any questions about that? That was kind of a bit complicated. No? You sure? Well, if you have any questions that do come up, check in the chat and I'll answer it when they come through. Yes, and then blood is pushed out of the atrium and into the right ventricle via the right atrioventricular valve or the tricuspid valve, which we discussed earlier. So now we're going to talk, so the left atrium doesn't really have anything that different to the right atrium. In fact, it probably just has less things. So it has all the same features. I just named it the right atrium because I talked about the right atrium. Thought I was going to talk about the left atrium and then realized it's the same. So all of this all applies to the left atrium as well. So then we have the ventricles. So their function is to pump blood back into circulation, so either to the lungs or to the body. So that's pulmonary circulation or systemic circulation. So their particular unique features, besides just being, chambers, are the trabeculae carneae. So these kind of are equivalent to the pectinate muscles. Why is my thing not working? Because, pectinate muscles there, trabeculae carneae here. So they basically, rigid bits of muscle. The way a person in the year above us taught me last year is that Kanye equals Kanye, and Kanye is always in your heart. And I don't know actually how useful it is, but it's just really funny. And I've never been able to forget that these exist. I can't remember what it is. I just remember that Kanye is always in your heart. Yeah, so the trabeculae carneae are ridges in the ventricular wall, or the atrial wall, and their function is kind of being theorized, but it's most likely to prevent suction that would occur with like a flat surfaced membrane. So if it had like a flat membrane, when it pumps, it might like suction like fluid back in, but with a flat surface membrane, it creates like turbulence and stuff, and it won't get stuck, and that would helps the heart pump more efficiently. These are a couple of like buzzwords: the moderator band and the papillary muscles. These are types of trabecular muscle, but we will talk about those later. So then you have the chordae tendineae and the papillary muscles. So papillary muscles, as we just mentioned, type of trabeculae carneae, and these are these blobs of muscle there. And the purpose of these blobs of muscle are to hold down your chordae tendineae, or your quote unquote heartstrings. So when people mention heartstrings, I mean, they do exist. It is your chordae tendineae. And these are essentially just like stringy bits of connective tissue. I think I mentioned it last week briefly, but they connect the valve leaflets to these papillary muscles. So as you can see here, you have the valve. When you have the pressure of blood up here, it'll push open the valve, it goes through. Your chordae tendineae will hold your valve open, because otherwise it would be like flapping in the wind, right? Not the wind, like the blood flow. It would just be, flapping everywhere. So it wouldn't really have any structure to it. So that's why you need these muscles and these heartstrings to like hold them in place to make sure, they do what they're meant to do. So if we want to look a little bit more closely at the right ventricle versus the left ventricle, I've kind of narrowed it down to like size, pressure, and like a couple of things. Once again, these tiny words and stuff, honestly, not super high yield. I just like found it interesting last year because like the fact that firstly they name all these things, secondly the fact that these actually have a purpose. And I had to look a lot of these things up after looking at the anatomy book from last year. So don't worry too much if they don't really make that much sense. You can always just look back at the slide, it's fine. So in terms of size, the left ventricle is bigger than the right ventricle. And the pressure in the left ventricle is higher than that in the right ventricle. And the reason for that is that, well, if you think about your right side, is just pumping to the lungs. Your lungs, they're pretty big, but like not nearly as big as your entire body. So that's why your left ventricle has to be bigger. It has more like muscle and needs to like, be able to pump harder to, get blood to the body. And that's also because the systemic circulation puts a lot more back pressure on the heart than the pulmonary circulation does. Therefore, the left heart has to be bigger and stronger. Now, this is where it gets a little bit like funky, a little bit like almost embryological. And this is the outflow tract to get to the great vessel. So let me go back to this photo. So as you can see here, the oh my god, words. The right-sided heart has this little bit here that's not really atria or ventricle, and the same thing with the left-sided heart. It's just this bit that's kind of just before, the valve, before you get into the proper vessel, but you're still part of the ventricle, but it's also like, not. And these are the outflow tracts, and they're outflow tracts because they flow out. And in the left ventricle, because it's going into the aorta, it is called the aortic vestibule. And a note about this is it has fibrous walls rather than muscular. So as you can see over here, it's hard to like really distinguish the aortic vestibule from the either of them from the actual, rest of the chamber, but it's just kind of an arbitrary thing. And this is fibrous walls instead of muscular, so that's the way that you can kind of identify it. On the right side, we have the conus arteriosus. So you can see that on the outside here, the conus arteriosus, and the exact same space on the inside is named the infundibulum. So like the same bit over here. So they call it the conus arteriosus, but it's also called the infundibulum. So if you see these, they're essentially the same thing. Yeah, so it's basically just the tapered bit of the ventricle that leads into the pulmonary trunk. And then they have things that separate the outflow tract from the inflow tract, because you don't want it to flow in and then like mingle with the blood that's trying to flow out, and then the blood flowing out trying to mingle with blood flowing in. So like it has some sort of structure to actually guide the blood around. We don't want it to go back into the atrium or something. So on the left side, your like kind of structure that separates that is basically just the anterior cusp of the mitral valve. So as you can see here, if that's the outflow tract, that's the anterior cusp of the valve. And on the right, it's your supraventricular crest. So here you can see it's highlighted, and it's this little bit of like raised tissue here, so that it goes in and then it kind of comes out through that way. Yeah, that's pretty much that. If that doesn't make sense, don't worry too much about it. It's just words. I was just trying to explain what the words mean. Yeah. Now this is where it gets slightly more important. So we're talking about conduction and conduction pathways. I believe Xenia probably talked about this last week, but I'm gonna talk more about like the anatomical part of it. So as you may know, the heart has conduction pathways for electrical impulses. That's what causes the heart to contract. And we talked about nodes last week. So we have your sino-atrial node, your atrioventricular node, and then it goes off and splits into a bunch of things. Yeah, so okay, I'm gonna presume that you guys kind of know somewhat about cardio like conduction based off last week. So your impulses come through the sinoatrial node, and that's like in the atrium, and so is the atrioventricular node. It's kind of closer to the ventricle side of the atrium. So you get your conduction comes through to the sinoatrial node, depolarizes, goes to the atrioventricular node, and that causes the atria to pump. And then it goes through, this is the septum that separates the ventricles. So it goes through this wall, and when it goes through this wall, it's called the bundle of His. So His bundle. Bundle of His. And then it kind of splits off into right bundle and left bundle. So your right bundle branches and your left bundle branches. So then they go down, and then as you can see, they're making their way up the sides of the heart on the right and the left. And then when it gets here, they are called Purkinje fibers. So SA node, AB node, bundle of His, bundle branches, Purkinje fibers. Yes. So then it does the atria first, and then the ventricles. And as you can imagine, you have to contract the atria to get it into the ventricles, and then the ventricles contract to get out to the body. And these nodes are made of special cells called pacemaker cells, which can make their own electrical impulses, as Xenia described all last week. And we have a chat. That is a good question. Are the pacemaker cells in the Purkinje fibers? I don't think the Purkinje fibers are specifically pacemaker cell. Xenia, would you be able to help me answer that one? I'm not entirely sure, actually. If Xenia is there. Xenia, send help. Okay. Well, technically speaking, the Purkinje fibers can generate like a heart rate. So if your SA node is fucked and your AB node is fucked, or if your AB node is fucked and then nothing can get past it, then your Purkinje fibers will actually generate some sort of a heartbeat, but it'll be extremely slow, and it'll be like 30 to 40 beats per minute kind of thing. So I don't think they necessarily produce their own electrical impulses. So the SA node and AB node are specialized to actually, send things through. But I think it's just like, it'll eventually depolarize and eventually repolarize and then eventually depolarize by itself, just by like movement of ions in and out. But I don't think it actively like creates an impulse, if that makes sense. Does that make sense? Yep, awesome. So all of that was just to be able to explain this, so possibly unnecessary. But there are particular parts when you actually look at the heart, like a specimen of the heart, you can actually use landmarks to figure out where these nodes would lie. So of course you can't actually see the nodes because they they're just cells. So they just look like everything else. But you can use certain structures to identify where they are. So your SA node, as we mentioned before, that thing called the crista terminalis, so you can see the crista terminalis here. It's at the junction of the crista terminalis and the opening of the superior vena cava. So your SA node is going to be located around here. Then you have your AV node at the triangle of Koch. This is like super high yield. They will ask you questions about this, like what are the structures that make up the triangle of Koch, and then be like, here's a multiple choice question, which one is/isn't part of it. And they like to ask you about it a lot. So the triangle of Koch is kind of like this imaginary triangle between these three particular structures. So you have your coronary sinus orifice. So there's a coronary sinus. As I mentioned, that's where the blood from the heart comes in. Your tendon of Todaro. So I was like, what the fuck is the tendon of Todaro? But it's basically, as I mentioned, the eustachian valve of the inferior vena cava before. So it has a valve, and then it's kind of just has like a little bit of like ridgy muscle that continues as like a a little ridge thing over here. Okay, thank you, Zenya. I'm not very good at phys. I'm more of an anatomy person. So yes, TYV, Zenya. So that's another part of the triangle, the tendon of Todaro. And then the septal leaflet of the mitral valve. So the valve has 3 leaflets. The septal leaflet is the one that's closest to the septum, like the wall that goes through the heart to separate the two halves. So that leaflet over there, kind of. So as you can kind of work out, kind of like it's a little bit of a rough triangle. But you have your tendon of Todaro, your coronary sinus, and like your leaflet. And then at the top of this triangle is the AV node. Honestly, this picture always confused me because like the triangle doesn't really look like it's going between the 3 points. But I don't know, look, anatomists just like come up with random shit, and that's one the shit that come up with. So well, if anything, just remember these 3 structures: the coronary sinus, the tendon of Todaro, and the septal leaflet of the mitral valve, or even just the mitral valve. Wait, mitral valve? I think I meant the tricuspid valve. Tricuspid valve, sorry. So because we're in the right side of the heart. So we're in the right atrium. So this is meant to be the tricuspid valve. Apologies. Tendon of Todaro, I just thought of Totoro, and I was like, oh no, Totoro. And then the heart one, and then the valve one. A couple more landmarks. The bundle of His is basically just in the interventricular septum. There's nothing in particular. As you can see, here's the wall, here's the bundle of His, and here are your bundle branches. So they just run through the wall. I guess the important thing is because it runs like in this wall here, there is specific blood supply that like it goes to these parts of the septum. So if you have like cardiovascular disease and you have atherosclerosis in like those arteries, or you have a heart attack and those arteries are blocked, it can actually threaten the conduction of the heart. And that's sometimes why people die from heart attacks, because your heart just, the tissue dies and then you can't pump your heart. Right bundle branch. Okay, so the right bundle branch is demarcated by this thing called the moderator band. It is also sometimes called septomarginal trabeculation. Trabeculation, if you remember the trabeculae carneae. Carneae is always in your heart. So it's a type of trabeculae carneae. So it's essentially, it's called that because it's just, really it is part of the heart wall, but it's a particular thickened part of the heart there. And this contains your right bundle branch. So like this bit here, as you can see, it goes through and through the moderator band like that. I don't know why it does that. It just does. The left side doesn't have anything like that. It's just in the right side has a moderator band, and it conveys your right bundle branch from the bundle of His. Yeah, not that important. Not that important either. Just like a thing that they'll sometimes mention the moderator band, and then you're like, bro, what the fuck is the moderator band? And then instead of having to Google it, you can come to the slides. Because I had to Google for a while. Okay. Now we're up to the stuff that is slightly more high yield. So borders and surfaces of the heart. When you're talking about the heart, you have Okay, firstly, you have two general points. So you have the apex and the base. Like kind of opposite to what you would think it is. The apex is actually the bottom of the heart, but it is the pointy bit. So they come into kind of a point here, the apex. The very important part here is it lies in the left fifth intercostal space at the midclavicular line. I don't know if I do continue on to talk about that soon. But that is a very important point. So the apex is there, the base is basically the opposite side, on the posterior side of the heart. Now, all of this is not super, okay, to be honest, this particular slide, not super high yield. The two bits that are highlighted, quite high yield. So the apex is important, and then the anterior side of the heart. They often like to ask you just a random question, which side of the heart is like most anterior? The question is the left ventricle. I said the right ventricle. I'm dumb. Okay, these two are meant to be swapped. So it's the left ventricle, I think. Wait, inferior from the left ventricle and aspects of the right ventricle, right pulmonary. Or am I dumb now? Sorry, my brain is not working particularly well. Or maybe it is the right ventricle. Could have sworn it was the left ventricle. Wait, I made these slides a while ago. Can anyone confirm or deny? Guys, leaving me out to dry. Okay.
I think it is the right ventricle.
Is it the right ventricle?
Yeah.
Yeah, okay. For some reason, I feel like left ventricle was something. Maybe that's the most inferior part.
Wait, left ventricle?
Yeah, I thought left ventricle did something. It was something of like.
Isn't it the most posterior part of the heart?
No, I think that's the right atrium.
That sounds questionable as well.
Or is it the left atrium? Do I have a brain? Sorry. I'm really tired. And we have 4 hours of Zoom following this, so I'm not looking forward to it. But okay, so I think the anterior side of the heart is formed by the right ventricle. Because as you can kind of see, like the heart is kind of turned this way. Like it points towards the left side. So your right atrium is back there somewhere, and then your right ventricle actually faces forward. Like so, the wall of the right ventricle faces most anterior. And then inferior is formed by the left ventricle and aspects of the right ventricle, just a little bit. And then right pulmonary and left pulmonary is right and left. Atrium and ventricle. Yeah, so Xenia also thinks left atrium is most posterior because as you can see, it's kind of turned like that. So I think it is the left atrium is more posterior. I'm sorry, we're a mess today. The 4 borders of the heart, not really that important. I didn't really remember them. Surface anatomy of the heart. Now this is the important stuff. So particular borders of the heart line up with locations on the surface of the thorax. So your superior border, you don't have to remember every single bit of this. But the apex is at the 5th intercostal space. Now, the reason why this is important is you feel the apex beat here. As we said, it's called the apex. So this is where the apex beat is felt. The reason why this is important is if you are trying to, if you actually like feel someone's chest and you go to the 5th intercostal space at the midclavicular line, you're supposed to be able to feel their heart. Worst case, you also, you take your stethoscope and you put your stethoscope there, you will be able to hear the apex beat at that point. Yes, so that's like where you can hear the heart most clearly, where you might be able to feel the heart if you palpate it on a person. 5th intercostal space in the clavicular line, extremely, extremely important. Yes. So this is the like high clinical skills kind of stuff. Yes, thank you to Jess, who has confirmed that right ventricle is most anterior and most posterior is left atrium. That is kind of important. They will ask you questions on that, just like in tute or like in a question or something. They will ask you that. And they'll try and trick you by like, yeah, anyway. So auscultation sites of the heart. Now this is like the high yield clinical skill stuff. As you can see, you can put your stethoscope at these different areas and you will hear different things at different valves. So the purpose of all these is to basically hear the valves. Are they working properly? Do we have any like pathologies there? And if there is some pathology, like if say, actually, I'll get to that in a second. I'll explain what all these auscultation sites are. So you have your aortic, your pulmonary, your tricuspid, and your mitral valves, right? As we discussed last week. Each of these spots can be heard at a specific point on your chest. So you're starting from here, your aortic valve, as you can see behind there, is your second intercostal space next to the sternum, so parasternal. So that's your aortic. Your pulmonary is the same spot on the opposite side of your sternum. So left second intercostal space next to your sternum. So they're quite easy to remember. They're essentially the same thing, just on opposite sides at the second intercostal space. And second intercostal space is your sternal angle of Louis, if you can remember that. The one where you feel here and then you can feel across, and that should be your second intercostal space. This is how you also find your auscultation sites. You don't just like, oh yeah, I think the second one's going to be there. You do feel for the sternal angle and then across and then go, okay, that's the second intercostal space. I'm going to put my stethoscope there. And then you have your tricuspid valve and your mitral valve. So your tricuspid valve, you feel at the kind of like the fourth intercostal space, sometimes the fifth intercostal space, depending like just on the person. So roughly around there. And that's also next to the sternum. So fourth, fifth parasternal. And then your mitral valve is also called the apex beat, as we just mentioned. So that's in your fifth intercostal space, mid-clavicular line. So all of them are next to the sternum except for the apex beat, which is at the mid-clavicular line. So that's kind of something you just have to remember. Like there's no way around it. Like it's just, you just have to remember it. And then you have to get good at like palpating down like second intercostal space, third intercostal space, fourth intercostal space, fifth intercostal space. Let's shuffle along until we get to the midclavicular line. Then we have your pathologies, which are murmurs. So your murmurs are like kind of like whooshing sounds that you'll hear during auscultation if there is a pathology. So if you think about it, like if your blood is trying to go through something, but like there's like a bit of plaque in the way, or your valve isn't opening all the way, it will become quite turbulent. And you know, if you swirl something around, it will make like a whooshing sound. So that is what that sound is. So these will be different depending on the pathology. It can be louder, it can be quieter, it can get loud and then get quiet, it can start quiet and get loud. And these, you know, it's due to where they are in the cardiac cycle, and you know, what valve they affect. I'm not going into too much detail here because I believe Fraser talks about it when she talks about pathology, and cardiac cycles, and your talked about last week. So yeah, it all depends. So, you know, you see mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, they all have different sounds. I'll quickly mention that stenosis is when like your valve is like stuck there so it can't open enough, and regurgitation is when it's like too floppy and it goes and then like just like, you know, just kind of flaps around. So now I'm going to talk a bit about the pericardium. So we mentioned the pleura last week, and the pericardium is a very similar concept. So the pericardium is like the sac that the heart sits in, just like how the pleura are the sac which the lungs sit in. And it is also innervated by the phrenic nerve. C345 keeps the diaphragm alive. It also keeps the pericardium alive, and it's the phrenic nerve. So as mentioned last week, similar to the diaphragm, if you have irritation of the pericardium, you may have referred pain to like your shoulder C3, C4, C5 area, because it is like your up there, if you have like a pathology. Yes, so you do technically have 3 layers, but 2 of them are part of like this continuous layer, similar to how the pleura are. So on the outside, you have your fibrous pericardium, and that's, just made up of like fibrous connective tissue. But on the inside, you have these 2 layers together are called the serous pericardium. So the fibrous or the serous pericardium. And the serous pericardium is made up of these 2 layers, your parietal and your visceral pericardium. So once again, that is very similar to the pleura. Your parietal is like more on the outside, and that is stuck to the like outer layer of the fibrous pericardium. And then your visceral is on the inside, and that is stuck to the heart. Yep, so it's very similar to the lungs, and like the pleura, you have a little bit of fluid in there generally, and that's just because your heart is beating a lot, and you want it to be like, you don't want a whole bunch of friction and stuff when that happens. So it's a little bit lubricated. Clinically, you have that space between these 2 layers called the pericardial cavity, very similar to the like pleural space. And I said usually has small amounts of fluid in it, just like pleural effusion. You can have pericardial effusion. Wow, incredible. Yeah, so pericardial effusion is just, if you're taking a look at the heart and you're like, oh, there's a little bit more fluid than usual. Once you have more fluid accumulating, and say you had like a bleed or like, some sort of infection or something like that, you can get like a lot of fluid accumulating around the heart. And as that increases and increases, it'll put more and more pressure on the heart. And that's when you start getting problems. And when you get to that point, it's called cardiac tamponade. This is like an emergency condition. If you are seeing someone in emergency, you always want to check for tamponade because it can be life-threatening. As I mentioned, the pericardium is innervated by the phrenic nerve, roots in the cervical spine, thus it can refer to the shoulder and neck, and sometimes down your arm. Yep. Finally, we're going to talk, I'm not sure about finally, but we're going to talk about, this is going to be a long presentation, I'm so sorry. Layers of the heart wall. So as you mentioned, you have your pericardium, and then you have your epicardium, which is also called your serous, and that is parietal and visceral. But when you're talking about layers of the heart wall, it is nicer to call it the epicardium because it matches up with the myocardium and the endocardium. So the epicardium is also considered part of the heart wall because your visceral pericardium is stuck to the heart wall. Yes, so you have your epicardium and then you have your myocardium. Myo means muscle. It's the muscular bit of the heart wall. And then you have your endocardium, which is the innermost layer of the heart wall. So epicardium, myocardium, endocardium. Yeah, I don't know if I have exactly like a way to remember that, except for myocardium kind of makes sense. Epi versus endo. I don't know. I'm sure there's some like etymology of those words, but yeah. Yeah, so now we're going to go on to some questions. Yes, okay. Xenia might do some phys next week. Yeah, I'm still wanting to go through like all of the vessels and like blood supply and shit, so it might be quite long. I'm so sorry. Yes, so okay, yeah, endo means inside. Thank you, Xenia. Okay, so question: which of these structures is not in the triangle of Koch? Oh, thanks, Donnie. Yeah, easy. So yes, what is the answer to this question? I mentioned I'll ask questions about it, and then I asked a question about it. Oh yeah, okay. This is just me making a mistake again because I took this from the slide. Yep. So it is C. B, as you're right, it is also wrong because that's meant to be the tricuspid valve. But if that was a tricuspid valve, it would be correct. Just to note, the mitral valve doesn't actually have a septal leaflet. So I don't really know what's happening in my brain. Because the mitral valve only has two leaflets, so it just says anterior and posterior. Yeah, so that's septal leaflet of the tricuspid valve, and the crista terminalis is not part of the tendon of Tadaro. It does indicate, however, where the SA node is, but not the AV node. Question 8. A man comes into the GP clinic complaining of palpitations, which is basically like when you can hear your heart beating. Where would you want to place the stethoscope to listen to the mitral valve? Yay. You listening? Yes. Mid-clavicular line. Mitral is mid-clavicular line. That's a good way of remembering it, Eminem. Okay. Yes, okay. This slide is just like a really random anatomical mention, but in our formative exam last semester, they like threw back to some cardio and gave us this exact picture, and they were like, "What is this?" And we were all like, "Bro, I don't remember any cardio. I don't know what that is." Bro, what do you mean Adelaide is funny? I'm in Adelaide.
Remember it.
Why Adelaideans, dude?
Yes.
Bro.
Bro.
Just because some of them do, I mean all of them do. Oh, what's Stella's superior version? Great, I'll let the chat go off and I'll talk about these sinuses. So yeah, so we were given this exact picture and they're like, what is this? And we're like, we can't remember. Got it wrong. But yeah, so there's something that's kind of easier explained when you can go into the anatomy lab and like actually stick your fingers like through these spaces. And these are kind of more important, like clinically, like in surgery, it allows you to, you know, put clamps in and stuff like that. So firstly, you have your transverse sinus, and it's essentially like this space where you can stick your finger behind the pulmonary trunk, behind the aorta, and then emerge in front of the SVC. The reason why this is important is that, like, if you're doing heart surgery, you don't want heart to be flowing in and out the, you know, heart while you're trying to do something down there. So you can actually ligate these vessels. So just like tie them off to make sure you're not getting like huge amounts of blood flow in there. And then you have the oblique sinus. So this one's like a little bit harder to conceptualize. It's literally if you stick your finger down behind the heart, like kind of from this angle and then in, there's actually like weirdly a hole there. Like, I don't know, your finger just goes and you're like, oh. And it's behind like this U-shaped section of pericardium. Yeah, so it runs down from the left atrium. I can't remember like what that's used for, but it was something that they, you know, asked us about and something that they wanted us to know. So there it is. It's just kind of weird. Like the reason why it's just the heart just be like that. Like I don't know. The body is just, you know, there's spaces. I have absolutely no explanation for it. Yes. So now this is like, this is pretty important. So the coronary arteries, as we mentioned, the coronary arteries supply the heart tissue, because the heart muscle needs to stay alive too. So the question is, where does this blood come from? There's no like huge vessel that goes there. So above the aortic valve, so this is like the opened up aortic valve with all its leaflets. And sorry, my thing is going off in the background. Let me turn that off. Yes, so above the aortic valve, you have these little things called aortic sinuses. So if you think about it, your blood is pushed out and goes up around the arch of aorta. But, you know, not all the blood is going to make it all the way around the arch. So when you have like your backflow can't go back into the heart. Firstly, that's bad. Secondly, the Oh, what's the valve is closed. Sorry, had a mental blank. The valve is closed, so it can't actually get back into the heart. So it lands in these leaflets and then flows into these aortic sinuses. So you don't like it's the heart isn't like directly pumping blood into these arteries, but like they get blood from the backflow of blood from the aorta. Yes, and then they run through and supply blood to the heart. So usually there are three sinuses: your right coronary, your left coronary, and your non-coronary. I don't know why it's called that, but it's like anterior, left posterior, right posterior. And the reason why is that that is the posterior cusp. These two actually, because it's a triangle, like, I don't know, it just kind of makes sense. You have like one that's properly anterior, and then the others are kind of like both posterior. Okay. Now I'm going to be talking through all the coronary arteries and like where they like branch from and how they run. And the reason why this is important is because when you have a heart attack, if one of these vessels is occluded, you need to know like what it supplies, what heart muscle might die, what is at risk, and what do we need to fix, right? So that's just a bit of context. If you are like, surely we don't need to know this. Usually, like I would say yes. You don't need to know every single branch, but there are some like really high yield branches that you do need to know. So the coronary arteries actually run in particular fat deposits in the heart wall, and they go and supply the myocardium. So in real life, all of these are just covered in fat, so you can't really see them. So they have some protection. And they supply the myocardium, so the muscle bit. So like the muscle needs a lot of nutrients and a lot of everything to continue pumping. So you have two main coronary arteries: your right coronary artery and your left coronary artery. So you can see your right. It comes out from there and kind of goes around, and then your left coronary artery is there, and then it comes around, kind of. So let's talk about your right coronary artery first. So your right coronary artery, it gives off a tiny branch to your SA node. It gives off a marginal branch. The marginal, it just goes along like the edge there. That supplies your right ventricle, and then travels along there to supply your apex. The coronary artery, it comes out of here and then it wraps around the side, like behind the heart. And then it gives off the AV node branch. And importantly, it gives off the posterior descending artery, or you can call it the posterior interventricular artery. And 60% of the time, it does get blood supply from this posterior descending artery, PDA, if you will. But 40% of the time it doesn't, and that is extremely important. We'll talk about that in a second. So just remember, PDA, keep that in mind. Left coronary artery. Now you have your big boy, the left anterior descending artery. This one here. What? Oh yeah, okay. Sorry, your left anterior descending artery is also called your anterior interventricular artery. Does that sound similar? It sounds similar to your descending interventricular artery. Anterior, posterior interventricular artery. Yes. So, posterior interventricular artery. Okay. Left anterior descending artery is your big boy. It does a lot of things. It comes around the anterior side of the heart. Yep, and that innervates the anterior 2/3 of your interventricular septum. So the septum between them, the anterior 2/3. Then you have your marginal artery that goes off the side there to left border. Your circumflex artery is this one, and it like circumflex because it circles back around. Sometimes the SA node artery comes off this branch. And then you have, okay, so do I explain it here? Okay. Your posterior interventricular artery, while it can come off your right coronary artery, it can sometimes come off your left coronary artery. and that supplies the posterior 1/3 of the interventricular septum. So you can see like a couple of things are coming back and recurring. So I'm going to explain it here. So these are the most high yield points. So firstly, your LAD. It is the largest coronary artery. If you think like, oh, what a LAD, you know, big boy. I don't know. I don't know. My brain's kind of falling apart. So that supplies the anterior 2/3 of the interventricular septum. So that always comes off the left coronary artery because it's in the name, left. And the important thing is this anastomoses with the posterior descending artery. So if you imagine the heart, the LAD comes down this side and does the anterior side, and then it connects with the posterior descending artery, and they form like a full kind of loop around the heart like that. And then, as I mentioned, your posterior descending artery supplies the posterior 1/3 of the interventricular septum. So this whole concept of heart dominance is extremely important. So heart dominance is essentially which coronary artery gives off this PDA. So as I mentioned, it can either come off the left or the right. So you either have left heart dominance or right heart dominance, or you can also have co-dominant. That kind of gets a little bit confusing. So just basically go left or right heart dominance. And left or right means, does the PDA come off the left coronary artery or the right coronary artery? So if you are left dominant, this is quite bad. Because so if you're left dominant, both the LAD and the PDA are given off by the left coronary artery. This means you're quite at high risk during a heart attack, because right, that means all of the blood to your interventricular septum is from your left coronary artery. So if you have a blocked LCA, you're gonna have absolutely no blood to the septum, and this will lead to tissue death, and then you can't conduct heart rhythm through your bundle of His or bundle branches, because as we mentioned before, they run through the interventricular septum. And this is why, so the LAD is sometimes called the widowmaker, because like you can die. But like if you think about it, if you're right dominant, on the other hand, like, okay, you've lost 2/3 of your septum. That is quite bad, but at least you have 1/3 of it that is untouched. So yeah, so I don't know if it's the LAD called a widowmaker or like being left dominant is, but like if you get a occlusion of your LAD, it can be called the widowmaker branch, which is a little bit bleak, but yes, dominance of the heart, extremely important. Now we're on to your coronary veins. I'm sorry, this is going for ages. So you have your cardiac arteries, the coronary arteries, as we just mentioned, all those things. Now we have your coronary veins. So, oh, actually, there was one last thing I wanted to mention about the coronary arteries, that we kind of were told by a wonderful third year a couple of days ago. If you have a heart attack, you can kind of tell, is it anterior, is it inferior, or is it like lateral, so like on that side? Or yeah, so if it's an anterior heart attack, it's going to be your LAD, because it's that one. If it's inferior, like kind of inferior, like the right ventricle over here kind of does like the inferior side, the right coronary artery, like it comes down and does that bit. So if it's an inferior heart attack, it's likely an occlusion of your right coronary artery. Anterior, it's probably occlusion of LAD. And then if it's like lateral, it's probably going to be your circumflex artery because it goes around that side. Okay, coronary veins. They return deoxygenated blood into the right atrium via the coronary sinus, which, as we said, is a structure in the triangle of Koch. It sometimes has a thing called the trapezium valve. I don't know if that's that important. I think they just mention it every now and then, so it's nice to know what it is. So you have the major vessels of the human heart, the major veins of the human heart. They are your great cardiac vein, your middle cardiac vein, and your small cardiac vein. And then you've got like all these random shit. Like I didn't actually know these last year. I just looked it up and like copied off Radiopedia when I had to make this slide because I didn't know what they were. But these three, they're quite important. So I guess I'll point them out here. So your coronary sinus comes out from there, and then no, it goes into your coronary sinus there. That's where it's aiming for. So this one here is your great cardiac vein. This one here is this one here at the back is your middle cardiac vein. And your small cardiac vein is this one on the side. So you're probably looking at this, right? And if you take a look at this, it kind of looks kind of similar. So you have one big boy going down there, one going down the back, which is your posterior descending, and this one that comes around here, which is your right coronary. So often, basically the way I remember these is that they're just complements of big arteries, right? So your great cardiac vein, it runs in the anterior interventricular groove. Basically between your ventricles, there's kind of like a bit of a groove that demarcates it on the front. Oh, I don't have it here, but I actually have like a 3D reconstruction of the heart. Shit, I should have brought that. I think it's in the next room. But yeah, so you have a great cardiac vein, and that drains the anterior aspect of the heart, and essentially it is the equivalent of the LAD. So that's a great cardiac vein. Middle cardiac vein, it can be called your posterior interventricular vein. That might help you remember that it accompanies the posterior interventricular artery. So they run together, and that runs at the back. Middle cardiac vein here. And then you have your small cardiac vein, runs in the atrioventricular groove, so between your right atrium and ventricle, and that follows the marginal artery from the right coronary artery. So in that kind of area. Yes, sometimes it can drain directly into the right atrium, but most of the time it'll drain into the coronary sinus. Yeah, just anatomical variation. I love it. And then this here is your coronary sinus. So technically speaking, the hole into the atrium is called the coronary sinus orifice, because that's the hole. The coronary sinus itself, like a sinus is basically like a place where a bunch of veins come together and form a chongus vein. Like you have a couple in your head as well, but basically they all come together, form the coronary sinus, big chunky boy, and then that drains into the heart, if that makes sense. Yep. So here's just another picture of it from Moore's. You have your great cardiac vein, your small cardiac vein, and your middle cardiac vein comes up around. Yeah, and as you can imagine, that kind of follows very similar to your LAD and your PDA, the way that works. And then your coronary sinus, the big chunky boy. More questions. Okay. Which of the following is true? Oh, do you guys understand systole and diastole? Okay. Xenia, did you teach systole and diastole last week? I don't know if Xenia's paying attention or not, but yeah, easy. Would you like to throw out a quick explanation of systole and diastole for people who don't know? I don't want to get it wrong, so I don't want to do it. Easy. So systole is when it's contracting and diastole is when it's relaxing. So with that information, you might be able to answer this question. So do they fill in systole or diastole, and where do your coronary vessels arise from? Yep. The answer is indeed D. So, yeah, so firstly, they arise at the aortic sinuses of the ascending aorta. Ascending aorta, arch, descending aorta. So it's not descending aorta, so you can immediately rule out A and C. So now you're like, is it systole or is it diastole? So if you can imagine it, the heart has just pumped blood out and then the blood is flowing back in. If it happened in systole, like your heart is contracting, it's like the valves Oh yeah, I should have mentioned this. So like when the heart is contracting, you know, blood is being pushed out of the valve. The valves, you know, kind of block off the aortic sinuses when it's open. You know, when it closes, you cannot access your aortic sinuses. They only fill during relaxation periods as it comes back down, because when it's contracted and the valves open, they're blocked. So they can only fill in diastole when the heart's just kind of at rest, not for very long, but like, you know, the blood will flow back and through. Yes, so they fill at the same time as the heart is filling up with blood. So when the heart is filling up with blood, it's not contracting, it's relaxing. Yes. Okay, question 10. A patient comes in with pain radiating down the left shoulder and arm, and they are known to have a left dominant heart. The cardiologist is immediately called very urgently. Why is that? Mm-hmm. Mm-hmm. That's right. I'm sorry. I'm really hungry. I'm just eating something. Risk of no blood to the septum. Great, easy. And that's dangerous because then your heart may stop beating, and then everything goes to shit. Oh God, I forgot I'm doing this today. Okay, cardiac embryology. I think you guys are actually doing this week, so it's quite important. And a lot of this will start making some of the cardiac anatomy make sense. Okay. Do you guys want me to go through this today, or do you guys want me to go through this next week? I am aware that we've been here for like an hour and a bit. There's like so we're here. Oh man. Okay. I mean, there's a lot more slides than, so it goes until there. So it's like this bit. Today, please. Yep. Easy. Okay. Let's go through some cardiac embryology, unless there are any other objections to that. Okay, let's go through it then. Okay, embryology. Basically, when you're a baby, you don't have air, right? So where you normally need to circulate things through the lungs, you no longer need, well, you don't need to yet. So your heart has like all these like secret passageways, secret tunnel. Yeah, so so since you can't get oxygen from your lungs, it receives oxygenated blood from the mum via the, you know, umbilical cord, or specifically the umbilical vein. So it's called a vein because it is going back to the heart. It directly goes into the heart, but it is carrying oxygenated blood. I'll do it again when we actually get to the bit. But yeah, so as you can see, this doesn't look, it looks like almost like a normal heart, but like not quite. Like you've got all these like weird things that are going on, and you're like, what is this? Why is it purple? Yes. So your fetal circulation is a lot different to your adult circulation. So usually, you know, IVC to SVC, go to the right atrium, to the right ventricle, to the pulmonary arteries, etc., etc. But all of this highlighted bit where it goes to the lungs, like you don't need it. Like you don't need lungs really much when you're in a fetus in a womb. So since we don't really need all of the blood to go to the lungs, because that's kind of unnecessary, you just need like a tiny little amount, like just to, you know, keep the lung tissue actually alive. So what you get is IVC to SVC into the right atrium, skip all that, go straight to the left atrium, to the left ventricle, and then to your ascending aorta. So the question is, how do you get from the right atrium to the left atrium? The solution is you punch a hole in the wall that separates them. Secret tunnel. And that is called the foramen ovale. Foramen, hole, ovale, it's like oval shaped. So you literally just have a hole in the wall here. No. Yes? This picture's a bit confusing. If you look at this picture here, right atrium through the foramen ovale, straight into the left atrium. Yes. So then I guess the next question is, what will happen if some blood doesn't go directly to the left atrium? What if it decides that it wants to go to the pulmonary artery, pulmonary trunk, and, you know, off to the lungs? We don't want that. So essentially, you connect the pulmonary trunk to the aorta because they're right next to each other. So pulmonary trunk, aorta, you connect them. And this little connection is called the ductus arteriosus. Oh yeah, there's your foramen ovale. Sorry, I just saw it. So basically your blood will flow from your umbilical vein into your right atrium, directly through and into your left atrium. If you have some bits that decide to go up here, you can let some of it go off, you know, go to the lungs, you know, you need to keep the lung alive, but you can also have this hole that will redirect blood down into the aorta. So it's all good. And then finally, we don't have an umbilical vein as an adult. So like, you know, how does the umbilical vein actually connect? This thing called the ductus venosus here. So the ductus venosus, like, I don't really know how to explain that, but usually your blood, like, it flows through your body and then it, you know, goes to the liver, it gets like cleaned and then, you know, keeps going. But your ductus venosus kind of connects your umbilical vein to your inferior vena cava here. So then you kind of combine your deoxygenated blood from like the body with your oxygenated blood from the umbilical vein. Okay, so these three highlighted ones, foramen ovale, ductus arteriosus, and ductus venosus, are your three key things when you're thinking about fetal circulation. Yeah, so this is just like another explanation of, like, in words, how it happens. Oxygenated blood comes in here via the ductus venosus, mixes with blood from the IVC, enters the right atrium, flows from the right atrium to the left atrium, and then continues out to the body. Or if it does go, that's the right ventricle, not the left ventricle, sorry. Or if it goes to the right ventricle, it'll go up to the pulmonary trunk and either go shunted back to the aorta via secret tunnel, or it'll go to the lungs to keep the tissue alive. So this mixed blood will leave via the umbilical arteries to be filtered by the mother because their liver doesn't actually really work properly yet, so it can't really filter the blood properly. So it goes to the mother, you know, cleans the blood, and then new blood comes in. So as I mentioned, you have your three important shunts. I want to note that in the adult, these structures kind of just close up and like and they don't have any function. They just, you know, shrivel up, unless you have a pathology, which we will get to. So yeah, so you have your shunt, the ductus venosus. As I mentioned, it's the one that it bypasses your liver. And yeah, so your liver doesn't work, so they're like, fuck the liver, we don't need to go there. So it bypasses your liver, goes straight to IVC. And the ductus venosus in adult, when it shrivels up, becomes the ligamentum venosum. So they call it a ligament, even though it's not actually a ligament, but it's not really a vessel anymore, so it's kind of just like tissue. Then you have your foramen ovale. So that bypasses the lungs because you don't need to go to lungs, it just goes into the left atrium. So it connects these two, and in the adult, it is called the fossa ovale. So eventually the fossa ovale closes up, and we will go through how the foramen ovale closes up to become the fossa ovale. And you'll notice this structure when you're looking at the wall of the atrium in the adult. Then you have your ductus arteriosus. This also bypasses the lungs by connecting these two. And in the adult, it's called the ligamentum arteriosum. Okay, so now we're going through the actual embryology stuff. Now this stuff, I hate embryology, but heart embryology kind of made sense. Except for this bit. I never understand when, as soon as I put these like funky photos, I don't know what they're talking about. but this kind of helped me visualize like what we're actually looking at here. So this blob is the yolk sac. This bit is what will become your embryo here. So maybe that will help a bit. So cranial caudal folding, realistically in the scheme of heart embryology, it's not that important to remember. Some people say, remember these days, day 18, day 22. I don't think we got a question on it. Nor have I really seen that many questions on it in the past. So I wouldn't necessarily remember it. You can if you want. So cranial caudal folding basically means you have your head, cranium, you have your tail, caudal, and then as your head grows big, right? So they're kind of like evenly spaced here. As soon as your head starts growing quite big, it'll just like flop down, right? And it has to curve inwards because it doesn't have anywhere else to go. So your big head flops downwards and curves. And if you can see the heart tube here, this tiny little bit here, as your head curls around, your heart tube is actually pushed from the kind of head area all the way into like kind of chest area there. Which is why your phrenic nerve, which innervates the pericardium, kind of originates like at your head/neck area, because it used to live kind of near the head and neck area. But then as it folds in and pushes the heart tube closer to the chest area, it pulls the heart down as well as neighboring structures. So that's why the phrenic nerve is like super long and it goes and innervates the heart. This is really the reason why they teach this. You don't have to get bogged down to details. Like it starts in this day and like this falls here and the yolk sac and the ectodermis. Fuck it. I don't understand it. This is what they really want you to know. Like the reason why it's C3, C4, C5, but it's in the chest, it's because of this. Now is the heart tube itself. Now this is a little bit more important. So by day 22, the heart is basically this long boy tube. You don't have any separation between oxygenated or deoxygenated blood. You don't have like half and half. The only differentiation between each section is that each section will become a different structure in the adult heart. You can't, but realistically, you can't really differentiate between these when you look at it. So the heart tube, it has 5 sections. So basically it comes in here and then out there. So your truncus arteriosus is your outflow tract. Your bulbus cordis, the primitive ventricle, the primitive atrium, and then your sinus venosus is your inflow tract. So as you can see, why is that the inflow tract and that's the outflow tract? Usually, it's the other way around. It's got a flip. Heart got to do a flip. So it folds and it kind of, I always thought it looks a little bit like a snail in these ones. But yeah, so how does this long boy tube start looking like a heart? So firstly, your bulbus cordis, which is this green bit here, it starts to get really big. And similar to how the head grows really big and just like flops, this also grows really big and flops. And then because that flops downwards, it kind of naturally pushes your primitive ventricles here backwards and upwards, or they like to call it dorsal and cranial in the fetus, until it is flush against the bulbus cordis, like that. And then your primitive atria kind of just like flip up and like straddle the truncus arteriosus. So now you have your atria above the ventricles. And here so a note though is that your primitive atrium isn't actually the adult atria. The primitive atrium is actually your auricles. And your atria are kind of more part of like, let's see. I can't remember. Yeah, so your primitive atria make up part of the atria, but like a lot of your atria are kind of just made off by like all the other sections coming together. So, which is why your auricles, as we mentioned, have different muscle types to your atria because they come from the primitive atrium, but your actual atria come from somewhere else, which is why they are structurally different. So now we want to talk about the adult equivalent of the different sections. I was honestly quite confused about why the atria don't have a specific section. They just kind of just come together. So your truncus arteriosus becomes your aorta/pulmonary trunk. The bulbus cordis becomes the right ventricle and the aortic outflow tract. So let's see, your bulbus cordis becomes your right ventricle and the outflow tract. Your primitive ventricle becomes left ventricle. Yeah, so your bulbus cordis is the right ventricle. The primitive ventricle is your left ventricle. The primitive atria become the auricles and a little part of the atria, and the sinus venosus becomes like a bunch of different things, essentially like your coronary sinus and stuff. This is kind of the explanation of why the sinus venosus is kind of weird. Basically, the sinus venosus merges with the right atrium. That creates your smooth tissue, and then you have your crista terminalis, that ridgy bit. That is where part of your sinus venosus was incorporated into the right atrium, which is why it's kind of a lump. And then the left horn of the coronary sinus will become, left horn of the sinus venosus becomes the coronary sinus. So that's like what that means. And here's like the explanation of that, but in picture form. To be honest, I didn't actually know this last year. So it's not super important to remember. It's kind of just like interesting to see how that works with the whole embryological stuff of the tissue types, but not that important. Septum formation. Now, it gets pretty complicated, but it's like extremely important to know. So your septum, as you remember, is just like the wall that goes between your heart like that, right? So we have a rough heart shape now, but like it is still one tube with no separation, so you need to build some walls. So firstly, you need to build your atrial septum. You need to build, so like these are the three walls that we need to build basically. We need to build the atrial septum, the ventricular septum, and then we need to divide the truncus arteriosus into like the pulmonary side and the aorta side. So the question is, why does it start this? How does it know to start? You have these things here called the endocardial cushion, and that forms in the middle of the heart, and that's kind of like the target that the walls are trying to grow towards. And I'm getting a phone call. Hold on, sorry. Wait, how do I? Hold on. Well, my was just my dad saying, go pick up a package from the front door. I'm like, bro. All right. So where was I up to? Yeah, so we have the endocardial cushion. And this kind of like puts off signals like grow towards me. Initially you have one at the front, one at the back, but they fuse to become one. Yeah, so I didn't really bother going through that. So without the endocardial cushion, if you didn't have it, so there's like a birth defect that can cause the endocardial cushion to not really function properly, you do not get any walls, which is quite bad. You know, your whole heart is just like open. So that's the importance of the endocardial cushion. So we'll start with the atrial septum. This is the most complicated one. All the other ones make a lot more sense. But yeah, so remember that we can't just make a wall. We have to be complicated and we have to make a wall with a hole in it, but not just any hole, right? The problem with having it just as a hole is that, you know, firstly, we don't want a hole to just like be there when the baby comes out of the womb. We want some sort of, and like when it's in the birth canal, it still needs this shunt, but as soon as it comes out, we cannot have the shunt there. But like, it's not just gonna grow over in like 10 seconds, right? Secondly, we want things to be able to flow from right to left, but not left to right. Why do I keep saying left to right? It's meant to be right to left. Oh, right, no, that makes sense, sorry. So we don't want things to be able to flow from left to right. We only want them going in one direction. So the solution, we make a hole, we stick a flap in front of it. So if you try and flow backwards, the flap closes and it can't go through. So, and when you start breathing, your pressures in the heart will change, and that will also close it up. Solution, we love it. And then eventually, once it's closed up, it can slowly like grow and solidify into like a hole, like just like a divot. Yeah. So this is how it's formed. So just like in terms of big picture, we are trying to make a wall with a flap in front of it, which can close. So firstly, you have the septum primum, or the first septum, right? So this starts growing, it develops and develops, and it's growing towards this endocardial cushion. So at the moment, you have this hole. So if you think about it, it's 3D, right? So like on the side, it looks like this. And as you can see, clearly there is a hole in it since it just hasn't finished growing yet. And this hole is called the ostium primum, or the first hole. So septum primum keeps growing, and then it reaches your endocardial cushion. So it covers that up. So this whole thing is filled. But then before it completely seals up, so as you can see, it's like just about to seal, another hole appears. So this is because of apoptosis. So the body is programming it to, die to create another hole, just before that finishes, because we, want blood to still be able to flow through. So before that closes, the ostium secundum opens up. Higher up there. Yep. So now you have your full, just context, we have our full thing, and we just have the ostium secundum. So we have our ostium secundum, and then your septum secundum starts growing towards the endocardial cushion. And it also creates a hole via apoptosis, which is just inferior to the ostium secundum. So you have this hole here in the septum secundum, and then that hole there, which is the ostium primum. Yes, ostium primum. Yes. So eventually, when everything finishes growing, this hole, this oval-shaped hole, is called the foramen ovale. So your septum secundum is a little bit thicker than your septum primum, which is quite thin. So, if you're going this way, your septum secundum is going to be quite strong. It's going to just stay in place and just, let the blood flow through. The septum primum is quite flimsy. So you have your blood, it can flow through the septum, the foramen ovale, and then through the ostium primum. And that's how it gets from the right to the left. But since this wall is quite flimsy, as soon as blood tries to flow back this way, this flimsy stuff will get flattened back against the septum secundum. So it'll immediately do and stick there. And so no blood can get through. And that allows, the reason why these holes don't line up is so that when they do seal against each other, they're not just sealing against another hole and blood can still get through, because that completely defeats the purpose. But since it's solid there, it allows them to be flat against each other and seal off the holes. Now, we're going to talk about how this closes. Does anyone have any questions about this formation? You do kind of need to know it. And it is quite confusing the first time you listen to it. Does anyone have any questions about that? I'll just do a recap. Septum primum goes down, hole closes, other hole opens up. Also, I think I was calling this the ostium primum, it's the ostium secundum, I'm sorry. So hole there, hole closes, hole appears, other one goes down, has a hole in it, blood can flow. That's basically it. This one gets flattened against this one if blood tries to flow this way. This one does not close because it's strong and it will keep going. Secret tunnel. Okay. So the foramen ovale works because that's thicker than that one. So in your fetus, your lungs are under quite high pressure because they're not being used. So if you can imagine, your lungs have high pressure. This backs up to the pulmonary trunk, which backs up to the right ventricle, which backs up to the right atrium. So the pressure in the atrium is quite high, right? So the pressure in the right atrium is higher than that in the left atrium. So even though the pressure is high, it is not going to affect the septum secundum, which is quite thick. However, it will push away the septum primum, which allows blood to pass through. Post-birth, however, you start breathing. And because you're breathing, it decreases the pressure in the lungs, which thus, backing all the way up, decreases the pressure in your right atrium. So now, pressure in the left atrium is higher than in the right atrium. So, your blood wants to flow from your left atrium to your right atrium now, but because of our floppy septum primum, it gets pushed flush against the septum secundum. The septum secundum isn't going to move. The septum primum is just going to be pushed flush against the septum secundum. So that closes off your hole. And they call it a physiological valve, like, because a valve, I guess, like, can let things through or doesn't let them through. So now it's just a physiological valve, but nothing can get through it. And eventually this will close over and be called the fossa ovalis. So it's still oval shaped, but it's no longer whole. It's just like a dip. Does that make sense? Hopefully. So before birth, high pressure in right atrium keeps everything open. After birth, you start breathing. Left atrium is high pressure, closes the hole. Hopefully that all makes sense. Okay, we're nearly in the home stretch. We're getting there. I'm so sorry, this takes way longer than I expected. But okay, your ventricular septum. It's a lot simpler. You don't need a hole. It literally just grows towards the endocardial cushion. That's basically it. The only special thing I could find really about it is that the septum has a membranous part and a muscular part. So the membranous part is close to kind of closer to the endocardial cushion. The muscular part makes up the vast majority of it. The muscular part goes from the wall upwards, but the membranous part actually goes from the endocardial cushion downwards, and then they meet. I think the only clinical importance is that because bundle of his, this bit is a lot thinner, so it's more vulnerable to defects, and that's pretty much it. Ventricular septum, easy, just grows. Yeah. Then you can see here the muscular portion growing up and the endocardial portion bit kind of growing down. Now, your truncus arteriosus, a little bit more complicated than your ventricles, not quite as complicated as your atria. So this process is called septation because you are growing a septum. And this kind of, because if you imagine your heart, it goes into the aorta, but the aorta kind of comes out the left side of the heart and it goes through your right side and it goes out your pulmonary trunk. And then the left side goes and comes out the aorta, which kind of pokes out the other side. So if you had a tube, it would just go wee. It wouldn't really work like that, right? So you need to align each side with the correct ventricle. So in development, the aorta is initially on the right and the pulmonary trunk is on the left. So this septum needs do a twisty twist so that it goes, when blood passes through, it'll go from like that and then like that. So it goes kind of in the opposite direction it starts going. Yeah, so then if you actually look at it in adult development, they're quite closely intertwined, the aorta and the pulmonary trunk. The aorta goes behind it and then comes in front of it. So this twisty twist is what causes them to be twisted together in adult development. And also, I wrote this myself and I can't really remember what this means. Naming of the cusps on aortic pulmonary valves. Aortic holding the posterior cusp. Oh, okay. So if you actually look at it, the naming of the cusps, the aortic valve has a posterior cusp and then like other names, and the pulmonary has an anterior cusp and other names, but they do not have like each other. And that's just because like your aorta develops more posteriorly to the pulmonary. Okay, hopefully that all makes sense. This is just like wall, twist, form. You don't really need to know that much. Ventricular septum is just wall, form. This one is very complicated shit. Yeah. Okay, so now we're going to talk about defects if something fucks up, right? So there are a whole bunch of things that can go wrong when the atria are trying to form. So atrial septal defect is failure of the septum to fuse together after birth, and this is also associated with fetal alcohol syndrome. So there are two ways this can happen. The patent foramen ovale is like the most likely cause of issue. As you can imagine, sometimes the foramen ovale doesn't quite close up as it should. And often that's a problem with the septum secundum. Sometimes you can have like secundum, septum pramen. I think it's like it doesn't like fuse together essentially. Essentially like the foramen ovale doesn't actually close up. You still have a hole there, right? So blood as an adult can still flow from right to left, which is not great. You'll get some oxygenated blood and deoxygenated blood and vice versa. And then you have ostium primum OSD. Oh, that's the one I'm talking about. Okay, so foramen ovale is just this one, and that's an issue with the septum secundum. It's like it doesn't close properly. And then you have ostium primum, atrial septal defect, and that's when your septum primum doesn't quite make it to the endocardial cushion, leaves that open. So then that is still open. So technically speaking, it's not the foramen ovale typical path that's open. Another pathway is still open, and that can be associated with Down syndrome. So now we're going to talk about like symptoms. So since the pressure on the left atrium is higher when you're born, right? It's mostly a problem when you're born because you're not meant to have a hole. Your left atrium pressure gets higher, right? So this will be pushing oxygenated blood into the right atrium. So I guess the thing is, right, it's like if you have a bit more oxygenated blood in your deoxygenated blood, like it's not that big of a deal. Like you're not going to have deoxygenated blood going to your extremities. So you're acyanotic, so cyan, like blue. So that means having like bluish extremities. So if you were getting deoxygenated blood in your oxygenated blood, that means like your extremities may not be getting enough oxygen, which is why you get like bluish extremities. And that happens when deoxygenated blood makes it into circulation. Or so you're acyanotic, so that does not happen in this one, right? No blue tips. You also have a split S2 sound, so that's your S1 sound and your S2 sound of your heart beating. Since there is going to be more blood being pushed out of your pulmonary valve, it takes longer for it to close than the aortic valve. Usually they close at the same time, which creates one sound, the S2 sound. But since it will take a little bit longer, they get a little bit out of sync, so you might hear a split S2 sound. So it'll be like the. You may also hear a little bit of systolic murmur due to blood crossing the defect and sounding turbulent. Other things are just like shortness of breath because you're not getting as much oxygenated blood out, fatigue, leg swelling, so like edema, excess fluid, heart palpitation, basically a bunch of bad stuff. I think stroke is more likely because you have this turbulent blood that increases risk of clots. The clots can go to your brain. Some complications are paradoxical embolism. So that's essentially, so this is like, worst case scenario. If you have a DVT, a clot may come loose and it's just like, yay, and it rises. So deep vein thrombosis can come about like if you have pre-existing like if you have surgery and you're lying there for a long time and your blood isn't moving, so it's just like stale and it performs a clot, or maybe you have clotting disorders and stuff, basically bad shit. So a deep vein thrombosis, if you have a little bit of a clot, it can come loose, rise the circulation all the way back into the right atrium. This can cross into the septal defect and into the left side of the heart, which can then be sent to the brain. Whereas usually your DVT will end up going to the lungs and causing a pulmonary embolism where it gets stuck in the lungs. But the reason why it's called paradoxical is because like it shouldn't end up in the brain, but it can. Then you have your, I hope that made sense. Let me know if that didn't make sense. Then you have your atrial arrhythmias, so, or like infective endocarditis, like that's just like, thing fucked with the heart, cause more heart fucked things. Yeah. And it just increases your risk of these things. So treatment is basically just surgical repair. If it's in children, sometimes it might actually repair itself because obviously children are still developing. So if you can monitor them for a little bit, you can see if it repairs itself. Often, like it won't actually cause that many issues, so you can afford to just see if it repairs itself. Then you have defects in your ventricle. Usually happens at the membranous part. It's usually asymptomatic. Yeah, like similar to the other one. If it's too big, then you can repair it, but usually it'll be fine. Like it's not going to cause too big of an issue. Very similar things to atrial septal defect. Then you have having a patent ductus arteriosus. So if you think back to our shunts, we had that shunt between the pulmonary trunk and the aorta, to bypass the lungs. So just as the foramen ovale may not close, the ductus arteriosus may not close. So what usually closes it off? Usually it's like something to do with like increased oxygen. The body is like, oh, time to close it. Or like some other like just, I don't know, signaling stuff, it will close it. There's nothing like specific I can like point you towards. But if either of these things aren't correct, so like the prostaglandin thing doesn't happen, that can keep the ductus arteriosus open. So that can actually cause a few more issues. So you can have respiratory issues because you have too much blood going to your lungs, or you can have heart hypertrophy. So hypertrophy is when it gets bigger. And since like you're trying to pump things to your body, but it keeps being lost to the pulmonary circulation. So in order to get the same amount of blood out to your body that you want, your heart needs to work harder, it needs to pump more, so these muscles get chongus, hypertrophy. Some treatments is just so NSAIDs, I don't know if we've done that yet, but they'll down-regulate prostaglandins because often the decrease in prostaglandin levels is what causes it to close, or you can just do it surgically. Now, finally, the most important point of like embryology in terms of clinical application, tetralogy of, I say phalate, some people say phalo, words, who knows, tetralogy. So the tetralogy basically means there are 4 things. And you can remember this by, okay, I say 4 things and then I say prove, but like E is just early surgical intervention, you need it. So the 4 things are pulmonary stenosis, so stenosis of the pulmonary valve, which means it's basically calcified and it's stiff and it can't move very well. Second is right ventricular hypertrophy. So as we said, the right ventricle is thick, strongest boy. Ventricular septal defect, where your septum is open, and something called an overriding aorta. All of these things I'm going to go on and explain, but as you can imagine, it's a combination of a lot of bad things. So this is a congenital disease. It can only be fixed by surgical repair. So let's go through each of these 4 things. So pulmonary stenosis, the thickening of the pulmonary valve so it becomes stiff and narrowed. So what does this do? It makes it harder for blood to flow through. Because it's hard for blood to flow through, right, the heart has to pump a lot harder to push this blood past this valve. So because of that, your muscle on your right ventricle becomes quite, it needs to become thicker and stronger, which leads to right ventricular hypertrophy. So all of these things are quite linked. So pulmonary stenosis causes right ventricular hypertrophy. And the degree of pulmonary stenosis will affect how much it is hypertrophied. Yep. So then we're going to talk about a ventricular septal defect. So this allows blood to flow from the right side to the left side because it no longer separates it. So this comes to the concept of the overriding aorta. So because we don't really have a septum that separates the outflow tract of the right ventricle and the left ventricle, the aorta kind of is like a little bit more centralized, like over both the right side and the left side. So there's your aorta bit here. Usually it's going to come out and up like that, but now it's kind of like over here. So because there's nothing really holding it in place, I guess. And this overriding aorta means that you can get blood from this side and blood from this side, both going into the aorta, which can cause problems. So you can get deoxygenated blood, blue blood, going into your systemic circulation. So that can cause cyanosis because you are getting blue blood into your systemic circulation. So your main factors are your pulmonary valve has lots of resistance. Therefore, your right ventricle has to be very powerful and pumps blood, to pump blood through there. But because it's so much more powerful than the left side, it can pump blood into the left side via the septal defect. Thus, once it's on that side, it will take the path of least resistance up the aorta. Hopefully that makes sense. It's exacerbated by the fact you have right ventricular hypertrophy. And having that in systemic circulation will cause cyanosis. So tetralogy of Fallot, you have cyanosis. Atrial septal defect, acyanotic. Yeah? Okay. So to treat this, you just have to fix it. Like you just have to surgically repair it. So you'll, block off the ventricular septal defect, and you'll repair your pulmonary valve so you can replace it with an artificial valve. And final questions. Okay. Final questions. I'm so glad you're still listening to me talk, but which of the following defects are in the tetralogy of Fallot? Indeed, it is D. So I basically just changed all of them ever so slightly. Please remember that it is right ventricular hypertrophy and not left ventricular hypertrophy. It will make sense if you think of P is pulmonary stenosis, and then your R is your right ventricular hypertrophy. Which of these is not a feature of fetal circulation? Nothing? Okay, fair enough. Okay, unless I fucked it up, but yeah, so you don't need blood to fill up the lungs entirely to help them develop. The lungs actually have high pressure, and that reduces the amount of circulating blood. But the ductus arteriosus does allow blood from the pulmonary trunk to the aorta. Can be kept open with prostaglandins, that is what it keeps it open. And the foramen ovale is lower than the ostium secundum, so that it can close up like that. And then we were getting to the cardiac phys that we were going to do today, but I didn't realize that my heart stuff would go for 2 hours. Oh my goodness. Yes, I'm so sorry that went for so long, but the heart is like this one tiny organ that is extremely complicated, and they really do give you like a week to learn it.